Hello, Igor. Thank you so much for joining us today. For those who may not know you yet, you are a physio with a lot of experience and one of the clinicians and researchers deeply involved in lower limb tendinopathies, especially Achilles, right?
Yes, that's right.
Okay. What I really appreciated in today's course was how you connected the latest evidence with real clinical practice. So I will tell to jump into the interview, or do you want to tell us something about you more?
Well, first of all, thank you for the interview. It's a pleasure for me to be interviewed by you. I'm very happy of this course here, and I was very humble for the invitation to come here to Romania. I didn't know how the level of physiotherapy is, and it reminds me a little bit of Spain, about Spain maybe a couple of years ago when it was starting, and I found very nice physiotherapists, and I hope that the course helped you. Basically, I can tell you that I've been working for 28 years now. I've been a general physiotherapist, always involved in sport, especially rugby, basketball, professional basketball. And in the last maybe, let's say 10 years, I did my PhD in Achilles tendinopathy with Dr. Pete Majoras in Australia. And yeah, from then I have done some studies in Achilles tendinopathy, and nowadays I try to find the gaps that I find clinically, I try to respond them with research. Okay, so I don't understand research without clinical
practice. Okay, so it's great to see people with that much experience being so motivated and passionate. So thank you again. The first question: many clinicians still view tendinopathy mainly as a structural or degenerative problem. In your lecture, you discussed mechanical, inflammatory, neurogenic, and even central pain-related models. How do you currently understand tendinopathy?
Well, I go a little bit outside and I take it like a broad term, okay? Tendinopathy, we cannot only rely on structural changes. Among the different models that have been explored, there is a little bit of truth in each of them, but it's a combination of them what we find. And we cannot only rely on the structural part, because then we rely on the bio part of the biopsychosocial part of a person, okay? So it's an injured tendon, a tendon that is asking us for help because maybe in a certain moment has done too much and wasn't prepared for that, but this is also affecting to the whole person. It's not only the structural part, it's also how this affects to that person and how it affects socially to this person.
So we must understand all the three parts: bio, psycho, and social of the tendinopathic.
That's it.
Yeah. Do you think clinicians still overestimate imaging findings?
Yeah, I think that's clear, and it's something that we need to be aware of, because for years we have used other tools, other tests to diagnose tendinopathy. We didn't need this imaging. Maybe for other things imaging is important. I can tell you that those guys that don't have an ultrasound device, they can also diagnose tendinopathy, and they can do good job treating people with tendinopathy. But it's like a trend now. Everyone is buying ultrasound devices, and it's not necessary.
Okay. So do you think this has an involvement in nocebo in patients, this imaging?
Yeah, it could be. For example, sometimes I see people that does like weekend courses and they buy a ultrasound device and they want to show the patient all they know about the imaging, etc. And sometimes I see a lot of sono speculation. So they try to find something that it's the only thing they know, but sometimes it's like they do wrong diagnosis, and especially it can be a very dangerous tool if we use it in a negative way. So we know, for example, placebo and the good messages help physios in taking good outcome of good results for treatment. But if we say something negative to the patient about the image, this gets into the brain of this patient and it's going to take more time to recover. For example, if I tell you, look, the tendon here has a black stain, it's a hypoechoic area, it is very degenerated, be careful because you might rupture this tendon if you go to high loads. This message is going to stay in the patient's mind, and not necessarily this is true.
So imaging may be a useful tool, but we must choose very good the moment when we use it, right?
And especially the message we are giving with what we see.
I understand. Thank
Because
you.
what we know is that we can see differences, we can see changes in the treatment of someone with a tendinopathy. We are going to see changes in the symptoms, but not necessarily we are going to see changes in the structure. So they don't follow the same path, okay? We can see maybe changes long term in some tendons, not in all of them.
In clinical practice and even in education, we still hear terms like tendinitis, tendinosis, and tendinopathy being used interchangeably. From your perspective, what is the most appropriate terminology today, and does the terminology we use actually matter clinically?
Well, it's not something that I think. We had a conference, International Tendinopathy Conference, back in 2018 in Groningen, in the Netherlands, and we did a consensus in terminology. So now the term should be used by everyone to involve both inflammatory and degenerative tendinopathy. The tendinitis or tendinosis should be tendinopathy. We all should stop saying tendinitis, tendinosis. We should be using the terminology tendinopathy.
Okay, so tendinopathy.
Yes.
If there is one thing you would want clinicians to truly understand about load management and tendinopathies, what would it be?
I would tell them that they need to ask the patient maybe if there have been any changes in the load, and try to identify what can have been the changes that have caused the beginning of this pain. But it's something that, as I said before, getting injured is multifactorial. One is going to be changes in load, but we are going to have patients that are predisposed to this to this injury.
Pathology. Yeah.
Pathology. Yeah.
So we must understand a lot of things about patients. But regarding to load, because everybody who treats tendinopathy has this thing with loading. How do we distinguish between a load tolerant and a load intolerant patient in practice?
In practice, okay. So first thing we need to recognize is what type of tolerance a patient has to load. So if someone comes to you with an Achilles tendinopathy, we need to try to find a pain test for this patient. So a test that we know or that we estimate that is going to be a little bit painful, and we want to see what's the response to that high amount of load of this patient. So for example, usually we are going to ask this patient to do 5 single leg hops, okay, without touching the heel of the floor, and then we are going to ask you from 0 to 10, what's the amount of pain? Some patients will say, okay, it's 2 out of 10, the others will say it's 8 out of 10.
I see.
We are interested in this, and also asking them, do you think you are going to have like irritation after some hours or tomorrow in the morning because of this? That's giving us the information to decide how we should start treating this patient.
Still regarding to load, how important are sudden changes in volume, intensity, footwear, or training surface? Can this lead to a tendinopathy?
Yes, of course they do. As I said, this is extrinsic factors. Okay, so one person has different factors that lead him to tendinopathy. Some of them are extrinsic, these ones related to load, and the other ones are intrinsic. It's like if I have metabolics, if I had this injury in the past, or if I'm weak, if I had cortisone injections, whatever. If we have someone that already has some intrinsic factors that can predispose this guy to tendinopathy, if we add some changes in load, we are facilitating the tendinopathy to appear. But if we have someone without any intrinsic factors, and it is good, and it's someone that is used to train and used to changing load, maybe that's not going to be a problem for this person.
So some of us can tolerate changes in load better than others, right?
Of course.
Okay. Looking back over the 10 years, what are the biggest things you used to do that you would probably not do anymore today regarding Achilles tendinopathy?
Well, let's say 10, let's say 20. When I finished at the school, we started to have the first treatments for Achilles tendinopathy that was based in the eccentric exercises of Artfreson. Most of research is based on these protocols, and they were very good. They are very good for certain patients, but what we know now is that some patients are not going to be responding well to this treatment. Especially, for example, people with insertional tendinopathy, they won't be good responders. People with metabolics, people more sedentary won't respond good. And now what we know is that these are some exercises that can improve certain patients that are not willing to have very high demands, or are not very athletic, are not thinking about running, jumping, etc., etc. So for a normal life that it's not very active, let's say for my parents or for my grandparents. But if I'm looking for someone that wants to practice a sport in medium high level, I need to be I need to further progress the exercises of the rehabilitation in terms of preparing them for high loads in the training or playing games.
Okay, so I need to go further in the treatment, maybe with plyometrics and stuff like this.
That's it.
Is Alfredson still a gold standard for tendinopathy, for Achilles tendinopathy?
I wouldn't say it's a gold standard. It's not a gold standard, but it's still a protocol that is used by loads of physios and doctors around the world.
How do you decide between heavy slow resistance, isometrics, plyometrics, or more elastic loading strategies for the patient in front of you?
Well, first you need to know what are the aims of these patients. What is the final goal of this patient? Is it someone that only wants to walk? Is it someone that wants to play football? Is it someone that wants to compete jumping hurdles, for example? If it's someone that is happy with walking, Alfredson might be a good option. But if we want someone to run or to do high demanding loads, we need to prepare them. We need to take them to the gym. First, load the tendons heavily, and then eventually, if the aim is to start doing fast loads, then we need to start doing some plyometrics and some running and some running technique exercises.
To make preparation for what will come in the future. So I loved what you said in the slide that biomechanics, it's a mess. On social media, we still see very simplified explanation about valgus, pronation, glute medius weakness, and so on. So what do you currently see? So how do you currently see the role of biomechanics in tendinopathy?
Well, in social media, we see a lot of things that are not evidence-based, and this is based on some papers that we can see now. We recently published a paper about what you find in
social media.
Well, not in social media, more in Google, but there's papers in social media, and what they find is that what is published in social media sometimes it doesn't really correlate with what clinical guidelines say, so we need to be careful with that. And when I say that biomechanics is a mess, is because I did one of the first studies of my PhD was a systematic review on what are the biomechanical alterations of people with Achilles tendinopathy during running and hopping, and what we found is that even if there are some impairments in biomechanics, most of them come from cross-sectional studies that are not very high quality studies, okay, and with very small sample sizes. So this doesn't really mean we can extrapolate that, but especially if this data is coming from cross-sectional studies, we cannot say that, for example, someone that overpronates is more likely to have an Achilles tendinopathy, because we need other type of studies. We need longitudinal prospective studies, and nowadays we don't have them. Okay, so there is more research needed to be sure of that. And less expert opinion. I see, because this is the lowest part of the pyramid. That's it. Okay, so are there still movement patterns that matter clinically? So are there some movement that you really look when you're treating patients with Achilles tendinopathy? Some, let's say, compensations and so on? Yeah, you can always find some compensations. What I basically do, I try to load locally. Okay, so for example, if I have someone with Achilles, I will go to target the soleus and the calf muscles. Okay, but eventually, maybe not in the first day, but then I will go and try to restore the strength of the glutes, or the hamstring, the quads, everything. It's not just one thing, but everything. We need to see the person like in a totality. Okay. What is missing in modern rehabilitation? Like, if you could change something in what people are doing in the more modern rehabilitation, what would it be? I mean, you can call me you can say that I'm old-fashioned now, but I'm missing the simple things. I'm missing not trying to be doing more trendy exercises than the other physios or posting things or whatever. What I learned is like we need to try to keep it simple. We need to listen to the patient, what he says. We need to assess what might be the risk factors or identify what factors have made this patient get injured, and then try to find the activities that cause pain, reduce them, and start doing some load progression, and try to educate this patient to avoid the same problems in the future, okay? But as far as I've been taught, you know, in tendinopathy and also in physiotherapy, it's like keep it simple. I mean, do better the simple things, and we don't need to be super fancy all the time.
For the clinicians here, in Romania, I mean, who would like to learn more from you, follow your research or attend future courses, where we can find you?
Well, I mean, my papers are in Google Scholar. If you want to, you can read my papers there. Achilles tendinopathy, you look at tendinopathy, Igor Sancho, you can find them. This is the first time I come in Romania. I think I'm coming next year again.
Okay.
And I'm also teaching in other countries like Italy, for example. I'm teaching in Spain, okay? But I mean, if they keep bringing me here, they can come to the course next year.
Sure. Do you post usually on social media?
I have an Instagram account. I think it's Physio Igor Sancho. You can follow me there. I'm not the one that it has so much time to post every day the things I do.
I see. Thank you. So Igor, thank you very much for your time. You are very clear in your information, and that guide us very, very well. And for helping bridge the gap between research and real clinical practice. We're looking forward for seeing your next practical session in Romania. Thank you.
Thank you very much. Thanks for the interview. A pleasure.